Welcome to our Facebook Live session on Talking with Your Healthcare Team, Shared Treatment Decision Making. My name is Gina Aracena, and I am excited to be your presenter for today's session. Before we begin with the program, we'd like to thank our sponsors, AbbVie, AstraZeneca, Bristol Myers Squibb, Genentech, Genmab, Ipsen, Merck, and Kyowa Kirin. I'd also like to share some information about the Lymphoma Research Foundation. We're the nation's largest nonprofit organization that focuses specifically on lymphoma, and our mission is to eradicate lymphoma and serve those touched by this disease. In addition to today's program, we have a variety of other programs and services available for you. One example is our LRF helpline, which serves to complement our patient education programs. The helpline has master's level trained staff who provide individualized information on all types of lymphomas, as well as information on treatment options, clinical trial navigation, and connections to resources such as financial assistance. We also offer a peer support program called the Lymphoma Support Network. Through the Lymphoma Support Network, we can connect patients and caregivers with others who have been through similar experiences for emotional support. In addition, LRF has free comprehensive disease guides and fact sheets, which can be ordered or downloaded on our website, lymphoma.org. We also offer a variety of other in-person and virtual educational programming, so you can continue learning about the latest updates throughout the year. And finally, we have an award-winning mobile app called Focus on Lymphoma that provides helpful disease content as well as unique tools to help you better manage your lymphoma. The app is available free of charge in the Apple App Store and in Google Play. If you have any questions, please feel free to post your questions in the comments below. Today, we will explore the concept of shared treatment decision-making in healthcare. We'll discuss its importance, the core principles guiding it, and provide practical examples, especially in the context of lymphoma subtypes. Shared treatment decision-making involves patients and their doctors discussing the available care options, weighing the risks and benefits, and then making a joint decision on the best course of action. This process encourages patients to be active participants in their own healthcare. Shared treatment decision-making is crucial because it respects patients' rights to be informed and involved in their healthcare decisions. It ensures that the care provided is aligned with the patient's values and preferences, leading to better health outcomes. The three core principles of shared treatment decision-making are recognizing and acknowledging that a decision is required, knowing and understanding the best available evidence, incorporating the patient's values and preferences into the decision. Now let's look at an example involving diffuse large B-cell lymphoma, which is the most common form of non-Hodgkin's lymphoma. DLBCL is an aggressive lymphoma that typically requires prompt treatment. The first-line treatment often includes a combination of chemotherapy and a monoclonal antibody, such as R-CHOP. Sometimes other drugs like etoposide are added to the regimen, forming a combination called EPOCH-R. Another treatment option could be Pola-R-CHP. Many patients with DLBCL initial treatment can lead to remission or a cure, but some may experience a relapse. In such cases, there are several treatment options available to them. Now, when discussing DLBCL with your doctor, consider asking, what new treatments are available for my type of DLBCL? If there is more than one treatment option for me, which is more appropriate for my case? How long will I be on this treatment? Is hospitalization needed for any of these treatments? If so, for how long? What is the goal of my treatment? Would a clinical trial be right for me? What are my options for if the first treatment does not work? Although DLBCL can often be cured, 30% to 40% of patients may experience relapse or refractory disease. In such cases, second-line treatments are necessary. These treatments can reduce symptoms, control cancer growth, provide a second chance for cure, and extend life. Options include chemoimmunotherapy, targeted therapy, bispecific antibodies like Epkinly or Columvi, CAR T cell therapy, including Yescarta, Breyanzi, and Kymriah, and stem cell transplants. If you have had more than one relapse, seeking a second opinion would be a good idea to get an understanding of your options and clinical trials that might be a possible route to take. For relapse or refractory DLBCL, ask your doctor, am I eligible for a stem cell transplant or is CAR T cell therapy a better option? If both CAR T cell and bispecifics are options for me, can I have one and get the other if I relapse? Why or why not? What are the benefits and risks of each of these treatments? Can we consider a bispecific antibody for my case? What is the goal of my treatment? And would a clinical trial be right for me? Follicular lymphoma is the most common indolent form of B-cell non-Hodgkin's lymphoma. First-line treatments for follicular lymphoma include radiation, chemotherapy, and chemoimmunotherapy regimens such as R-CHOP and R-bendamustine. Many patients achieve durable remission that lasts for years, but follicular lymphoma is generally considered a chronic condition that can relapse or become refractory. When discussing follicular lymphoma with your doctor, consider these questions. Is active surveillance an option for me? How will my care be managed during active surveillance? Is radiation alone an option for me? If not, how many rounds of chemotherapy will I need? How will I know if maintenance therapy is an option for me? How often and for how long will I receive this treatment? For relapse or refractory follicular lymphoma, second-line therapies are often effective in providing another remission. Patients might not need immediate treatment and can be monitored through active surveillance. Treatment options for relapse FL, including the same first-line therapies as well as additional treatments such as bispecific antibody Lunsumio, which was recently approved for relapse refractory follicular lymphoma after 2 or more lines of systemic treatment, and CAR T cell therapy, which include Yescarta, Breyanzi, and Kymriah. Please note that many patients can achieve remission after second or even third line treatments. Although remission is in the range of 1 year or longer, can be seen with some treatments, it may be shorter with each round of therapy. Some important questions include, can I use the same treatment I used previously before my relapse? What is the latest treatment for relapse follicular lymphoma? In what order can I take approved treatments for relapse or refractory follicular lymphoma? What will my treatment schedule be? What are the possible side effects of treatment? Would a clinical trial be right for me? Chronic lymphocytic leukemia and small lymphocytic lymphoma are slow-growing forms of non-Hodgkin's lymphoma. Treatment for CLL, SLL depends on the severity of symptoms and can also depend on the identification of specific markers and whether these cells have certain genetic mutations in the DNA. Treatment can include drugs like venetoclax with or without Gazyva, Calquence with or without Gazyva, Brukinsa, Imbruvica with or without Rituxan, and Imbruvica with or without Gazyva. Active surveillance is an option for patients with minimal symptoms. Please note that in the past, chemoimmunotherapy was used, but now is not a common approach due to effectiveness and newer therapies. When discussing CLL, SLL with your doctor, ask, is active surveillance an option for me? What kind of tests will be done to look for changes during active surveillance, and how often will I need these tests? Can you explain what the term genetic marker means and why it's important to me? Do I need to be tested for these markers? What are some treatments that could work for me? Are all treatments given for the same amount of time? For relapse or refractory CLL, SLL, treatment options include targeted therapies and immunotherapy such as Imbruvica, Calquence, venetoclax with or without Rituxan, Brukinsa, and Jaypirca. Factors influencing treatment decisions include the patient's age, overall health, and previous treatment responses. Note that there are other treatments available or currently being developed. Please discuss these potential options with your doctor. Now, for relapse refractory CLL, SLL, consider asking, what is the most common treatment for patients who relapse with CLL? What are the pros and cons of my treatment choices? Are targeted therapy drugs an option for me? If so, how do they work? What happens if my next treatment doesn't work? Would a clinical trial be right for me? Shared decision making is vital for rare lymphomas like T cell lymphomas and CNS lymphomas due to the limited treatment options. It is important to incorporate patient preferences and seek second opinions or clinical trials when appropriate. Additionally, the Foundation is here to help with this important step through our helpline. Feel free to call us 1 800 500 9976. We can guide you in finding an institution that may result in a better option for you and your needs. Additionally, we can also conduct a search for clinical trials using clinicaltrials.gov. Some questions for rare lymphomas might be, what treatments are available for my type of lymphoma? If there is more than one treatment option, which is more appropriate for my case? What are the benefits and risks of each treatment? How long will I be on this treatment? Is hospitalization needed for any of these treatments? If so, for how long? What is the goal of my treatment? Would a clinical trial be right for me? Thank you for joining us today. For more information, please visit lymphoma.org or contact our helpline at 1 800 599 76. Remember, being actively involved in shared decision making with your healthcare team can significantly improve your treatment outcomes and overall experience.